And some days it would be so bad that I can't even get up from bed. And so now I'm hearing on the social media and from various people that this is a problem and nobody's listening to it. So I had already started looking into long COVID. At that time, long COVID was not even a thing. In October 2021, I had already started looking for autoantibodies in those patients who had COVID and thereafter 3 months later.
Welcome to the Expand podcast, where we unlock the secrets of respiratory health for healthcare professionals. Join leading experts as we dive into chronic lung diseases and expand your practice.
Today we're going to have Dr. Manali Mukherjee. She's invited for these podcasts, and she's assistant professor in respirology at the Firestone Institute, McMaster University. She's well known as a translational scientist. She's going to talk to us in their area of expertise in chronic respiratory disease with the special focus on autoimmune responses and the role in the disease severity, but particularly in the context here of COVID and long COVID. She has led the research area in long autoimmunity and biomarker, earning her the Emerging Researcher Award in allergic asthma, one of the chronic airway disease that we know very well. Her lab, funded by various sources, including industry, tackles a project on disease mechanism and biomarker validation in asthma, COVID-19, and also lung cancer. I'd like to welcome Dr. Manali Mukherjee. Dr. Mukherjee, you don't mind if I call you Manali during the intro?
Please call me
Manali. Thank you very much for doing that with us. I'm sure we're going to learn a lot and have a very open discussion. Why did you choose, to study chronic lung disease, or primarily chronic airway disease?
You know, I'm born and raised in India. And I think sometimes whatever we do in our life, the passion or the purpose that we pick up, they're often fueled by your early life experiences and personal or family experiences. Being brought up in India with a mother who was ailing from severe asthma and a grandmother who was underdiagnosed and unfortunately succumbed to chronic COPD, non-smoker COPD, it kind of told me that how ill lung diseases are managed. And thereafter, my mom she got diagnosed with lung cancer later on. I think it's the personal and the family experiences, and then noting that how, if there is diabetes or a cardiac issue or cardiovascular, there's a lot of research, lots to see on the internet, lots to do, lots of information out there, good clinicians. But I often found that lung diseases, interestingly, are not as well researched upon as other like diabetes or heart diseases. When I started studying with the thought process of going into medicine, being a physician, that's what my parents wanted me to be. One of the chapters that came across was I remember asthma and COPD, and what really bothered me was how come from just studying it, I could understand these are two different diseases, and yet they had the same treatment.
You have a good point, because it's very clear we're talking of cancer, all sort of cancer. We're talking of a cardiovascular disease. We're talking of diabetes. But it's true that there is lack of awareness, and research hasn't been invested as much, because not the same level of funding.
Yeah.
What I'd like about reading on your work, and you're at McMaster University, you're a translational scientist. What is a translational scientist, and why this is important in the research team to have people like you?
I think the way I look into it is that it's important to understand what is driving a disease. Of course, symptoms never lie. So you look at the symptoms, but often the symptoms can be the same across four people, which comes across as what is called as a phenotype. But the same symptoms can be driven by a number of different things that underlie.
Hmm.
And often, if we do not find the right method or the tool to figure out what is actually driving the disease, how will you effectively treat them? And I think in today's age and world, where we proudly say this is our age of precision medicine, let's be precise about it. How will you be precise about it if you don't pick up the tools that make you precise about it? So that's where people like me, scientists like me, come into the picture who actually know how to use those tools. You have a question, a clinician finds the question in the clinic because you can see the problems when you're seeing a patient. When you have that right dialogue or the communication with the scientific community, and the scientific community, like scientists, needs to be also well trained in the clinical
Yeah,
problems too.
absolutely.
We cannot stay in our labs with our lab coats on. We need to understand what are the issues that the clinicians are facing, or else we'll find that one molecule and run behind a tail like that. So it's important to have that open communication between clinics and the lab so that we can understand where is the question, and then we can figure out what are the best tools to answer that question. And
That's interesting, because very often people see like there is a drug discovery, and then from that discovery in the lab, then certain of these molecules will turn into drug, and that would be tested in clinic. But there is more than that, because what you're explaining here is that the discovery in certain technique also will allow, if you translating that into practice, would allow to be more precise in finding a very specific characteristic of the patient that would then allow the clinician to have some target treatment. And I think you have example of that. You've been working in some of these technique that may be very complicated, they're used in research, but now you want to turn that into something more simple and use in clinical practice, isn't it?
yes, yes. So it's like the whole concept is to pick up the right drug for the right patient to get the right outcome,
Yeah.
right? So I'm going to give an example of what I was trained at. So when I came here as a postdoctoral fellow, I started working on severe asthma, which is a complex airways disease. And it's more severe than those, like it's not just simply somebody taking an inhaler and being fine. There is a subset of patients who require more than just an inhaler, who requires those horrible oral corticosteroid drugs, ends up in hospitalization. So there's something more that's driving the disease. So for a very long time, I'm at Forest Stone Institute, where sputum, or looking into the airway, is how they have been treating these patients and what has been in their routine practice. And what it does is it looks directly into the airway to pick up which are the cells that are causing it.
Mm-hmm.
So one of the white blood cell that actually is very well associated, which drives the severity of this disease, are called eosinophils. Now, if I look in the blood, it might not always be reflective of what is going in the airway, because there is a two compartment, right? The lung is highly compartmentalized. So when you look into the airway, by just looking into the sputum, you can figure out, is this patient...
That's the best way, because you're directly in the airway. Yeah.
Blood is much more simpler.
Yeah.
Sputum is a little bit more difficult. So, but it's not as actually that difficult as one would think of. I think what we don't know of, we are always more afraid to start it. Right?
Okay,
but
yeah.
I think there is need for knowledge mobilization, exactly what you're doing. So it's perfect. There is need for knowledge translation, not just to the clinicians or the tertiary clinics, but to the community physicians as well as the primary physicians, and thereafter the community at large, so that they can go and tell their physician, saying that, I have heard about this technique or this tool that you can better assess what my symptoms are. Is there a possibility of doing that? And now what I am doing as a scientist, one of the things that I realized in the last almost 10 years now that I've been working on it, is that the main reason that has been stopping this going into practice is the ease of it. So we are finding ways of making it a little bit more easy. So something that can be more easily adapted into a hospital setting rather than having a new setting that will require some form of a capital
Yeah.
establishment. So this is where translational science and translational scientists like me really come in. And I think it's really important for scientists who are in the making right now, who are studying, to think about it in a way where they latch on with a clinician or a clinical lab, and not just do meta-analysis, but actually go in, understand what the patient population is. And for MDs who are studying, who are in the residence or your clinical fellow, latch on with a translational lab like ours, so that you understand where you can put your clinical questions and really that driving question into place. I think Canada right now really requires MD PhDs from the time of Freddie Hargreave, and
I cannot agree more with you. And the people who listen here, decision maker, the physicians, scientists like you in basic science, and public patient, I think it's very important what you just explained, that people understand this is why a country had to invest in research. In these teams where you have a scientist from basic science research that had worked with other people or working as translational scientists, because this has direct application into the change, and this is what can transform. And instead of adopting what other have discovered, then this is discovery from Canada. It's, well, we talking about all of this, and it's we could go over and over again, but I like your example. It's not only about drug, it's about application in the practice, giving tool to the physician. And the tool we have nowadays, it's not only like a stethoscope, it's about getting even more precise in some technique that can be done in research, translated into practice, being simplified, and then from there we can have precision medicine, the right treatment to the right patient at the right time. One thing that is particularly interesting about you, and thanks for, with your permission, we can talk about this, is that COVID, we're going to talk about COVID and how this may be important in your research and the discovery and the lung itself also. Some people being at higher risk with COPD or asthma, but you have COVID and you have what we call lung COVID. Then as a person, like any of us can be sick. You've been sick and you've been through that experience, and what it is about long COVID and how this has changed the way now that you're approaching your research.
Right. So what happened was, after I got COVID, it took a while to get better. And when I say while, usually what happens, you're young, you get a kind of a flu or something, it's a little bit more difficult. Maybe the malaise will stay for maybe another week or so. But here it was not a week, it was taking longer and longer. And I kind of I got COVID in Jan 2021, literally 2 weeks before I was supposed to get vaccinated. So by that time we were kind of already aware of how the acute symptoms we're looking at, how what were associated with mortality, what was associated, what are the risk factors. So by that time, because my background was in immunology and I was researching into different sorts of pathomechanisms of chronic lung disease, one of them being autoimmunity, there were three key cardinal features that I started picking up during the acute infection itself. So when I was seeing the different patients, so I was part of an ICU study at that time at St. Joe's, where my lab is. And from that, I had this very bad inkling that patients who would have a very severe form of COVID will have this lymphopenia, which is basically reduction in the total number of blood cells. Usually the body comes back to homeostasis. It'll want to come back to the natural level. But when it comes back to the natural level, sometimes the body does not come back to it as it should. So the number of cells as it should be, it can be reduced, whatever. The point is that it goes towards a deviation. So any deviation from health is disease. So that was one factor. There was a lot of hyperinflammation that was associated with the acute COVID. So when I got COVID, thank God I didn't need to be hospitalized or something, but I was very symptomatic and sick. And that kept on for a while. Then I started realizing myself from my symptoms that, this is not normal. This is not a normal getting out of a flu or something. This is going on, uncharacteristic. Then I started reaching out on patient forums, right? I was looking out, and especially because I'm a very social media enthusiast person on Twitter, I started looking a lot of people talking about this long hauler symptom.
Now we're
And
beyond the acute phase here.
beyond the
We're
acute
kind
phase
of
here.
recovery from the acute, but then you
Right.
remain with some symptoms and you're not back to what you would say you're
Not back
normal.
to your 100%, not even back to your 80%. So from my angle, I was basically running on fumes, like
Mhm.
40%, maybe even lower. And some days it would be so bad that I can't even get up from bed. And so now I'm hearing on the social media and from various people that this is a problem and nobody's listening to it. Now, I think when you do science and when you start getting training in a subject and you do way more into it, like doing a PhD, which means you know nothing in the end, somehow somehow the clairvoyance kicks in, right? So I had already started looking into long COVID. At that time, long COVID was not even a thing. So when in January I got sick, before that in October 2021, I had already started looking for autoantibodies in those patients who had COVID and thereafter 3 months later. And
What is a two antibody,
yeah,
Manali? Just for people's
I'll
sake
come
to
to it. Yeah.
understand, because you bring this term now. Yeah.
Yes. So I have to bring this term. So what autoantibodies mean is that the body's usual immune system is to create antibodies against a foreign object, so that you
Okay.
can they can save you from that attack. It's more like the police are making their gunshots. But when the gunshots ends up firing at your own self, so these antibodies
Okay.
recognize your own self structure, it actually becomes a problem rather than a like it's more of a curse than a boon, right? So that's when it's called an autoimmune disease. It's when your own immune system turns rogue against you and starts
Okay.
attacking yourself.
Okay.
And it can come across as various different symptoms. And
Okay.
and that's what was happening after COVID. And this is something that we started predicting, and I had already started looking into some of the patients that I already had with my collaborators here at McMaster, and I had started getting a little bit of data. So my plan was to put in the CIHR next call to look into this, and that's when I got sick. And when I got sick, that's when I realized that this is really a problem. So I got even a little bit more motivated. By that time, I had got in touch with the patient forum. Susie Golding was one of the person who was at Oakville. She actually opened the long haulers COVID network. I started interacting with her, and it actually helped me understand what they were going through. So for example, as a translational scientist, I was not much into subjective outcomes or patient reported outcomes. But that made me realize I have to put in patient reported outcomes, because that is what a community physician will hear from a patient. So then maybe I can associate it, the patient reported outcomes, with whatever I find in the lab as a molecular research, right? So that, I think, getting sick myself and understanding, having the empathy to connect with those who are sick, helped me understand this facet of the research tool that I was previously not so into. Maybe I would go for an asthma control questionnaire, ACQ5, or an SGRQ, which we often use, which are validated questionnaires for understanding, say, COPD or asthma. But this is a new disease, a new entity, which is not even called a disease. How do you understand that subjective response with your quantitative response? So I think if I hadn't got in touch with the patient community, because I was sick myself and trying to find an answer, I wouldn't have found that facet of my research.
But that's interesting, because that's moving research from the bench to the bed. Okay, where is the patient? Okay, and you obviously that's show the importance of. We don't wish that the people doing research are going to have the disease that they're searching on, and some of these diseases are obviously more severe than others. But it's a good example of how, when you understand what the patient are going through, either through engaging patient in your research, and that's the best way, even for us as clinician and scientists, where we work with patient,
Yeah.
we're closer to the patient, but it's engaging the patient is really key here. And that's what you've done, okay? And it has transformed the way you're looking at your research at the bench to find a solution to the patient, and that has been really transformative in your approach, and people that you're working with, as well as patient being at the center of this the center of this research. Do we know about, when we're talking of autoimmunity in the lung? Okay, what do we know about COVID now, and that autoimmunity in term of the long term complications such as long COVID?
Okay. So one of the first hypotheses or the thought process that I had was the lung is the main seat of infection in COVID. So if there is and one of the main patient reported outcome was breathlessness, and it was mostly exertional breathlessness, as in with exercise the patients were more
Yeah.
short of breath. I myself, I was seeing that. Like, I'm a
Okay.
trained vocalist singer, I couldn't sing as well, and I could see I was getting breathless when I would walk more or take a flight of steps, and so there was breath. So I was like, it has something to do with the lungs then. So it could be, like I have seen in my other research previous to COVID, that there could be inflammation that is compartmentalized within your lung. And when that inflammation is not resolved, which means it is not taken care of, then it keeps on staying and it leads into something worse, where the body
Okay.
starts to turn against you. Again, what I talked
Ag-
about, attacking yourself, the rogue autoantibodies.
Like to immunity, that's what you described earlier on, that your own cell, instead of just fighting the enemy,
Fights
you
you.
become part of the enemy and fight your own cell. Yeah.
Yeah. It's like some collateral damage which
Yeah.
happens, right? So because I had the tools to look for it, I started looking for it. But I started looking for it in both blood and in both the airway samples. Okay. And I was wondering if I could find something that is causing in the airway and if there is inflammation. So what I ended up finding was more systemic, which means it was affecting the whole body.
Outside the lung, not only in the
Not
lung.
just only
Okay.
in the lung,
Okay.
like I see
Okay.
in, say, severe asthma, but this is like holistic. It's like systemic.
Okay.
Okay, because the virus was also affecting the others. So there's a whole component when there is a problem with the leaky gut, that they say that even the intestines are affected and there is inflammation there. So I don't think it is just to the airway, it goes beyond.
Okay.
So that is the reason why I started seeing or started detecting inflammation. So there were inflammatory markers, cytokines that gets increased, which kind of propels the inflammation, and the autoantibodies that I could detect. So one of the first data that came out of my lab showed that if you have these two specific autoantibodies, they predict who will have shortness of breath at 12 months
Okay.
after the
Okay.
infection. So
Okay.
after 12 months from their first infection, if they're still breathless or if they're still chronically fatigued, then these are the two autoantibodies that are usually seen in these people. Very low
And there
type.
would be, that would lead into a way, because the problem we have now is we know that COVID has complication associated to a certain personal determinants, such as age, even sex, people being obese, and some comorbidity like asthma, COPD, where it triggers in the lung. Yeah, diabetes. But what you're talking about is that we until now we didn't have a way to predict not only what people will have in terms of complication of the lung, those that had certain comorbidity in the lung are at risk of complication, hospitalization, and even mortality. But it's going in the whole system as an autoimmune response, and in giving symptoms that are not only respiratory but could be in other system, what we call systemic. And now we would have a way that we could predict who, by measuring those markers in the blood, I presume, or is there a way?
Blood.
Do we know, and can we use that as it is now, or is still in research and it would need some refinement before we can use that and say, oh, now we can target these people and we can see if any kind of early treatment. Now let's study early treatment, see if we can change the course of that, what is coming, the long COVID.
Yeah. So the tool that I use, it is something that is available. It's a kit that I use. It's a diagnostic kit for anti-nuclear antibodies. There's a reason why I specifically started looking for those markers. It's just the science, the rationale of the science of how acute COVID was. But that kit is very much available in Europe. It's licensed, but
Okay.
also you can use kits similar diagnostic, because ANAs are done clinically, right?
Okay.
ANAs are done clinically, so your anti-nuclear antibodies are done clinically. What, however, I would suggest is to look at a lower titer, which means a lower level of it. Usually, if you go to a rheumatologist who looks for autoimmune, who studies and treats autoimmune disease, they will look for a very high level of these autoantibodies. What I'm suggesting is just go for a lower level as well.
Okay.
Because if
Okay.
a lower level of autoantibody keeps on persisting and that associates with your symptoms, it just means there might be a lower grade of inflammation, like a low fever continuously, that makes you feel malaised, that doesn't want to make you go to work or giving you, it's basically taking away from your quality of life and your productivity. And if you look at the population that we're looking at who are getting affected most, it's the working population, 25 to 55, and
Okay.
and a massive female component of it. Now, if there is a sex related or a gender related immunopathology associated, there's a lot of work going on in that. But the point is that
Okay.
people are sick. It needs to be like, you need to look at it. The second thing that I keep on telling the patients who are in my trial is that, give it some time. Don't be so anxious. Pace yourself out. So I often refer to the Recipe Plus Living with Long COVID,
Yeah.
the
That's
document that we
yeah.
prepared,
Thanks.
is that sometimes you have to just pace yourself out. That's what I did with myself. I just learned to accept, and then I just paced myself out. It took me 18 months to get back to my
Wow.
75%. 18 months,
Wow.
right? So, I mean, I know that I'll never get back to my 100%, but okay, 75, 80%, I can be happy with compared to
Wow.
what it was before. But
We
once,
have no cure for that now. Well, what is the best way that we know? Obviously, vaccination for COVID, while you can, is it known, okay, to prevent the long COVID? It can prevent the complication of COVID. Well,
it's a little bit more complicated than that, because I think what COVID is doing, it's affecting on the individual level. Again, we are coming back to the endotyping and the precision medicine of it, right? So it's not like a one size fits all. So on the in general, if I look at people who got COVID before they got vaccinated compared to people who got COVID after they're vaccinated, the amount of residual inflammation, as in the inflammation
yeah.
that persists after the infection, or the time length of it, it somehow improved. But
Okay.
that is not for everybody, again, because people who got vaccinated, even if it's 1 in 500,000, they got
Yeah.
affected.
Yeah. Yeah.
Yeah. So that's why we are calling it a post COVID condition instead of just post COVID or long COVID. So, you know what? Sometimes I can also see a lot of people who are saying, oh, my long COVID symptoms were lot more attenuated after I got vaccinated. Whereas some of the patient reported symptoms that I'm hearing from my study is they're like, oh, I was a little bit more chronically fatigued for 2 months. I was personally fatigued after 2 months of getting vaccinated, but I will get vaccinated because it will
Yeah.
stop
Because
me from getting the next infection, right? Because I don't know what the next infection will do to me. So it makes more sense for me to be vaccinated than
and the
not be.
vaccination, as we know for now, okay, seems to have it, like we know it
It
prevent the
lowers.
complication such as more severe disease,
Absolutely.
hospitalization, mortality, and
Yeah.
especially in very high risk group. But
Yeah.
for the long COVID, where we believe that it's related to some degree of systemic inflammation, in people that had the vaccine, these people seems to have less of this inflammation, or to a lower degree than those who didn't have the vaccine. This is what we know as of today. If I kind of try to give a summary for people that are listening, then vaccination has a role in preventing severe
Acute COVID.
complications,
Yeah.
may have a role also in reducing this systemic inflammation for the people who might develop it. Obviously,
Yes.
it's not an absolute. Nothing is 100%, like it is often in medicine, but you're better to take the chance of going with the vaccine, preventing that, than not going with the vaccine and getting a bad result at
Yeah.
the end.
And I think that the vaccines have saved way more lives. I mean, the numbers are
Yeah.
very clear. So if you want to go with the numbers, I think the vaccines have saved way more lives and kept our elders out of the ICU, and has helped the healthcare system to again gain back its stability. Because I think it's our healthcare workers and the healthcare system that were completely completely crushed under this
On the
the number of ICU and the number of severe complications that happen in the early phase. Right now, it's not so bad at all. In fact, vaccinations have helped reduce that burst of acute complications. We are dealing with long COVID, because I also think with another problem with long COVID is, I don't know, John, if you would agree with me. I think what happened was, initially, the medical community was so much into keeping people out of the ICU and keeping people
Mm,
alive, that they did not think about what is going on with the survivors.
absolutely. Yeah.
And I think that's where that whole point of anxiety and neglect came in. Because I was thinking from my point as well, being trained in immunology, I was getting anxious as to, why am I not feeling 100% better? Is my smell not coming back? Why am I smelling smoke?
Mm,
All those weird things, right? So even if I can tell myself this can happen after a viral disease, imagine those who are not trained in immunology, they will get anxious. And when people don't know about something, that always brings in the conspiracy theorists and all those unknowns and vagabond
wow.
thought processes. So I think that's what happened, and that's when a lot of people came together and started making big deal. And the sheer numbers that were affected, I think, added fuel to fire than what it is right now. If you look at it, it's only 15% to 20% of people who got the infection has the long COVID symptoms, as in symptoms persisting 3 months and beyond. If you look at the research that is coming all across the world, including Canada, including my own study, I can see that people who are showing long COVID symptoms at 3 months or 6 months, over the time by 12 or 20 months, they do get better. Like the
Okay.
symptoms actually reduce. And I can also see that the molecular markers in the blood are also reducing. But
Okay.
that is not true for all long COVID patients. There is about a subset of patients who are still reporting symptoms beyond 1 year.
Okay.
Okay. Problem is, the problem is that a lot of them will eventually develop some sort of a complication, which is immunology based.
Mm.
And most of them are rheumatologic complications. Like I'm seeing from my study, there are patients who were previously perfectly healthy, now has lupus, or now has
Those
rheumatoid
are kind of,
arthritis or
for
myositis.
people, those are kind of rheumatology disease that are called autoimmune
Autoimmune disease.
disease, that we still don't know exactly the origin, what had been the trigger. But what you're saying is that some of the people we know with long COVID now, that
Yeah.
could probably be a trigger. Then there is no treatment for long COVID as it is now. But these research you're doing might lead, okay, in the future into some targeted treatment on the immune system. But we're not yet there. That the way to do treat it is to prevent as much as we can.
So yeah, exactly. So prevent. So get vaccinated, mask. If you know you're in a high risk zone, like protect yourself. That's the best way of not getting long COVID, is to not get COVID. A. B is, there is this whole consortium of people. It's the long COVID web. John, I don't know if you're aware of it.
Okay.
The long
Yeah.
COVID web is about 200 to 250 investigators pan Canada that has come together. They're a web of clinicians, translation scientists like myself, basic scientists, policymakers, patient partners,
Okay. Good.
all of them who have come together under the leadership of Dr. Angela Chung from UHN, Simone Decurie, Adira Levine. I am heading one of the biomedical pillar with Jim Russell from UBC and Amelia Falcone from Montreal. So we are looking at the various facets of long COVID and seeing if we can find something that is a biomarker that will tell us these are the patients who might go to recover, which is great news because that's what you would want, or these are the patients who might need a medical intervention, and exactly which type,
Yeah.
right? So there is a lot of work going on there. There is already another trial that's going on. There are little trials going everywhere trying to understand what it is. And with the long COVID web, we are just trying to bring it all under one umbrella so that the biomedical scientists like myself, we try to understand the underlying problem or figure out the biomarkers. And then there is a clinical team who will help use those biomarkers to try for clinical trials. Then we have the health and the population scientists who will try and understand how that affects the population and the factor of it. So I think we have come across beautifully trying to figure out a problem, seeing the problem and trying to figure it out together.
That's very encouraging, because what you're telling us, Manali, is that the scientific community had react from the COVID. It's not over yet. And they have got together. And this is where it is important that some of the funding go to this research, because now it's not a matter of one person. It's not a matter of one institution. It's a matter of the whole community, Canadian and worldwide, that work together, trying to find solution. That's for the scientific community. But let's say, and you brought that earlier on, I kind of like, your approach now, because you're thinking patient and public population. Then what would be the place where you would say to people, because you were reassured by understanding better those symptoms that you had, those were kind of normal symptoms for a long COVID. How should you react to that? What it is about long COVID, and is the public can go somewhere where they can find that information and what to do and not to do for what we know now, in more in terms of general information of long COVID. You mentioned about living well with long COVID. Will that be a place where...
That's a fantastic resource, I believe. I think it's very important not to go and just ask Dr. Google, but rather find the right place, because credibility of information is extremely important. I would like to quote Harari, one of my favorite authors: in this world full of irrelevant information, clarity is power. So it's very, very important to get clear, precise information. And if you're not getting it, reach out to somebody like that, like us, right? I get emails every other day from community at large who will write to me asking, and I am more than happy, and I always respond back, because I think it's important that we give the right source of information.
And what would you recommend at the end, like a place to go? Sure, you don't want to receive all the email, but please, go ahead of what would be the place you would recommend for.
So 3 places that I would recommend. One, if you're trying to understand how to deal with your long COVID symptom and you're aware you already have long COVID. So I think the handbook that Respi Plus has brought out, taking the experts, like I was also one of them, a part of it.
Involved,
so living well with with the long COVID is a good handbook to look over. I think it really is helpful. It also gives you an idea of how to deal with your symptoms, how to pace out. Some of the stuff I have practiced myself, which has helped. Second is go on the long COVID website, which is our Canadian post-COVID-19 condition base. So if you just Google it, you will find it. It is the Canadian one, which is the government one. You can look at the basics of the main information that's out there, including the stats and everything. You can go over into my lab website, which is mukherjeexlab.com. You can go into Long COVID Web, which has a number of information right there. You can go into COVID Immunity Task Force or CITF website. So there are lots of good website, credible website where you'll get good information. And please reach out to the right people and reach out to the right website to get the information that you need.
This is very useful and very inspiring to see that someone in research and back now to a good health that can contribute, and you can continue to contribute quite a bit. I think we understand better now why the long immunity is important. What are the consequence of this phenomenon of auto immune response? That is giving certain disease, such as chronic disease like long COVID, and beyond the acute problem that where the focus has been primarily during the pandemic. Now we are dealing with the consequence of people that are still getting the disease, because it's endemic now and COVID is there to stay. And it's very encouraging to see that there is research going on in Canada, such as in your lab and your institution at McMaster University. What will be the last message you'd like to give to to people that are listening to you in terms of your research, in terms of COVID and in terms of long COVID, that people can remember, okay, that this is why, okay, that this is really important and what you've been doing is important?
I think the most important thing is what this pandemic taught us is that outreach of scientific knowledge to the community at large is important. And I think what the community understood is to come out and share their problems with the medical community, and having that two-way dialogue actually is the most important thing that advances science, which advances where science should go. And I think together we are facing it as a community. Just need to have faith and time, and we will get the answers. We have already come a long way, right? So this is the
Absolutely.
generation of instant gratification, instant coffee and Instagram and instant CT. I mean, we got a vaccine in 9 months after the pandemic was
This is unbelievable.
yeah, unbelievable. Which means that if we come together, great things can be achieved. So it's about staying positive, believing in the system, having faith, and only good things can happen. More negativity comes in, more conspiracy theories comes in, it only causes more chaos. So I just think that sometimes it's just to believe in the system, that there'll be some good that will come out of it.
Thank you so much, Dr. Mukherjee. It was a real pleasure to have you, and I'm sure people understand certain things much better now, and we're certainly going to come back to you at some point in time with discovery, those discovery being in practice and changing the way that we approach certain diseases such as COVID and chronic airway disease also, and coming with solutions that we can change, okay, in our population in Canada and worldwide. We need people like you. Thank you very much.
Thank you.
Thanks for listening to the Expand podcast. Stay tuned and listen to other episodes on chroniclungdiseases.com/podcast.